So it's 3, 2, 1. We are live now, so you can start the session. Over to you.
Hello.
Yes, sir. We are live now. You can start the session.
I cannot see the video.
But sir, your view is visible, sir. Yeah, you can start.
Okay, I can start. Okay, thank you. Good evening, everyone. I'm Dr. Nitesh, a consultant urologist at Ford Hospital, Patna, and I own my clinic Sri Kripa Urocare. Today, I'll be talking on supine PCNL, how I do it, the tips, tricks, and the difficulties I faced. When we see PCNL, we see it as a treatment of choice for renal stones more than 2 centimeters. And the traditional position is prone for PCNL and it's favored by many urologists because it's familiar with the procedure. It's what we are trained with and what we are getting trained in the institutions because it provides a larger surface area for the choice of puncture site and it's a potentially more direct approach. If anyone thought of a PCNL in the past, they would think from behind because kidney is behind. Nobody would have thought it from doing it from the front and from the lateral side because it was in the posterior aspect. So when we see the innovations in PCNL technique, how the timeline changed. In 1998, the supine PCNL was introduced, and sequentially after supine PCNL was introduced, we changed into RIRS, the endoscopic guided access. And when endoscopic guided access was introduced, some Gustis tried endoscopic combined intrarenal surgery, the SCBS. And we are also getting miniaturization of the scope from going from mini to micro. We are going into ultra mini and we are going tubeless to completely tubeless techniques. But the question will remain as because there's a mineralization that's a different aspect, but the question to which position is best for the PCNL still remains because there are lots of position despite from prone. I've just heard that even in prone somebody is putting bolster, somebody is not putting bolster, somebody is doing slightly tilted, and there's a belief think that whatever suits them, they are doing it. And at the end of the day, or at the end of the procedure, you have done a PCNL successfully only if you have removed the stone and the patient is stone free and there is no bleeding, there's a safe access, there's a safe exit, and the patient is happy, you are happy. But my belief is the supine PCNL will become standard of care in around 5 to 10 years. When we see the supine positioning, the original position was Valdivia supine position, then it was modified many times by Gladeco, and then there was Bart's techniques, the Bart's flank-free supine position, the supine oblique, semi-supine, completely supine, left lateral flank position, modified complete supine position. After reading all these, I don't know what my exact position is, how to define that position, but let's pay tribute to Valdivia sir, which has introduced the supine PCNL. In his position, a 3-liter sac is placed in the right lumbar fossa, and it the patient lies completely supine. The legs are completely extended. When it was modified, the legs were slightly put apart so that endoscopic access also could be possible. Dr. Gusti modified this technique. He put a roll in the back of the patient completely from the shoulder to the buttocks, and the legs, one leg was, ipsilateral leg was kept completely extended, and the contralateral leg was placed in a lithotomy position for combined access. And he's doing very nice job with the SCBS. In Bart's flank free position, the flanks are free. The bolsters are kept in the buttocks and on the chest, and flank is elevated. It hangs down, and the patient is in lithotomy position. The legs are slightly extended on the side, and contralateral side slightly abducted and flexed. So, I will not go into the details why supine and not prone, and what are the advantages of one over the other because it has been talked a lot of times. Rather, I will put forth my journey from prone to supine PCNLs, the challenges I faced, how I adapted them, and the several other advantages which I've discovered in supine PCNL. So how I started supine, my initial case selection. I remember my journey when I was a resident. I've done around, after doing around 100 PCNLs, I was almost okay, let's do something new. So something new, what came up in our mind, because there was no lasers, no RIS available. So we wanted to do something new. So we thought we'll do supine PCNL. Every day when the PCNL was posted in the OT, we'll go to our assistant professor and we'll ask, sir, today we'll try supine position. And he will say, no, dilatation is not that much. We'll wait for a case which has much more dilatation. Uh, the same thing kept going over, and almost after 2 months, we got a case in which the kidney was baggy and there was a small stone sitting in the pelvis. So he gave up his thumbs up. Okay, you can go for supine in that case. And that was the first time we did it. I've done around 3-4 cases in my residency. After I came in my practice and I started my private practice, I started selecting cases earlier, which were small stones in the pelvis, in which I could puncture any calyx I want, and there's no need to puncture a different calyx. So we started like that, and gradually there was one stone in which the stone was in pelvis, but during breaking it went into the upper pole, and I could not retrieve the stone. The patient was in spinal. By the time I turned him, he was almost the effect was gone, and I could not do it on the same setting. So I had to redo the case. So that was an initial hiccup. I was afraid to go into the upper pole or the patient in which upper pole puncture was required. But gradually, as I adapted the technique, I knew the difficulties I faced, I knew the challenges, and I adapted to them. Then I gradually went to going for a superior calyceal puncture, and then to complete Staghorns, and even to the other things which has multiple stones in kidney, which requires multiple punctures. And I'm doing all my cases in supine, and recently I've completed around 200 cases in supine PCNL. So we'll start with the first thing, the positioning and setup and the anesthesia. The patient, my patient position is patient lies supine in the bed, and there's a small roll almost around half thickness of the NS bottle, which you can see on the shoulders, and the small roll is kept on the below the buttock, and a small 500 ml NS bottle is kept below the shoulder, and so hands are slightly, or hands are kept on the chest. This is the position I keep, and anesthesia is almost always supine. And if the procedure goes long, anesthetist is very happy to proceed with or supplement with TIBA, or if needed, he can go directly to the GA. He has a good access. He is happy with that. The patient, his head also turns to the opposite side, and then he can watch the procedure. He is less tensed. His movements are less jerky, respiratory movements, and you can see in this, the contralateral leg is placed in a abducted and lithotomy position. The ipsilateral leg is placed on a stirrup. I'm planning to put the leg straight, but I'm not getting that parting table, or it's not easily available. And in all hospitals or some freelance hospitals, it's not available. So I modified to this. I keep the one roll on the below the buttock, and one small NS bottle on the just below the scapula. That's it. Nothing else. When you see the OT setup, this CM is in the center. The TV screen is on the left side, and the CM screen is on the right side. So I have equal access to all this, both the screens. The CM is almost in a fixed position. Once it's fixed, the paddle will lie on the left foot of the CM. I can control the CM. I do not need an assistant to repeatedly press the CM. So one person is less in the OT, and there's a less chaos, less exposure, or less man force needed. The litho button or the this paddle or the laser paddle will lie on my right hand. On my right side, or you can say if I'm doing the left side, on my left side there will be the trolley. So I take usually a rotating chair. I could rotate and take things from there. So after you place the patient in I call it a flying free semi oblique modified lithotomy position, but I'm not sure the others. It's almost different from every other surgeons I am doing seeing the supine position slightly different, and whatever suits you, it's the best. Even prone, if suits you, if you're able to do stone clearance in prone is better for you. But putting the electric catheter after that, it just patient is in lithotomy position, you just go with the same nephroscope, you put a electric catheter and just keep the instrument on the patient body, or you can just dismantle it and keep it on the tray, and just you can rotate. You have to come back to the patient side. That's it. Your 10 minutes of flipping the patient and re-dripping, or even 15-20 minutes the patient is hefty, you'll need 2 to 3%. It's gone. Once my OT is set up, I only need 2% inside the OT, and there's no need of other persons. You go there, you keep the electric catheter in your hand because it will be available to you. You do your RGP, your foot pedal is in your control, the exposure is minimized. After that, you do a puncture. In puncture, the initial problem which we face is a orientation, that we tend to go down below the, this is the marking which we do usually, the 11th rib and 12th rib and the mid axillary line. I usually do not mark in any of the cases. I just marked it for taking the picture or for demonstration. Just to see the highest point of iliac crest, and that's it. That's the posterior axillary line. You have to be behind it. So when we start puncturing, we usually do not go straight. We go down as we go in a prone position. So this is the habit we need to change. And you have to go either parallel to the skin, or if your puncture site is slightly below or away from the posterior axillary line, or parallel to the flow, or if your puncture is slightly below, you need to go slightly cephalline. Okay. So this is the first mistake we do, and it needs correction. It will come by practice. No need. You can try supine. If it doesn't work for you, you can always flip the patient. There's a chance you can always complete your procedure, but do not take up initially for the big stones, because flipping everything will cost you time and it will be a problematic affair. So regarding the puncture always it's said it's nothing new for a supine or a prone puncture, that puncture should be on the tip of the calyx, or that it should be centered going through the calyx, not through the infundibulum. The guide wire should go nicely, all the things. We are not going to repeat that. The only thing after puncture, one more thing which reduces your time is you do not need a syringe. You do not need to aspirate. Urine will come. If urine is not coming, your puncture is not inside. You're not inside in supine PCNL. That's a, you can make it as a dictum. If urine is coming or if water is coming, you are inside. If it's not, you're not inside. One more thing in puncture, we are mostly taught the triangulation technique and the this bullseye technique. But in supine PCNL, if you want to do supine PCNL, you have to get accustomed, or you have to get very confident with a freehand puncture technique, because triangulation, it's difficult job in supine. Again, you will need a third person to do 0-30 or cephalad 30 or 0 or the chordate 30, or you need for a bullseye, you need C arm to be almost horizontal, that C should be under the table or even above the table, and you need to stay away. I've seen, I forgot his name, surgeon urologist from Korea doing like this. He keeps the C arm C below the table, and he'll hold the needle with a artery forceps, mosquito forceps, put a bullseye, and then we'll puncture. Yes, puncture is good, technique is good, but we'll need these uh, extra persons and extra time. So if you are habituated, if you are expert in freehand guided technique, you can do it. By the time, by the experience, you will know whether you are anterior to the kidney or posterior to the kidney. Contrary to this prone PCNL, kidney rotates more, kidney is more freely mobile in supine PCNL. So if suppose you are going anteriorly, so kidney will move in a different fashion, the calyces will get oriented in a different fashion, and if you're behind, more behind, this will get oriented in a different fashion. So you need to adjust accordingly. And the time, most of the time, around 90% of the time, I go inside in a first go. 10% it takes around 2 to 3 puncture attempt. Usually I will go in a first attempt. So after puncture, putting is the guide wire. Putting the guide wire is almost the same. What I do, a different thing, I put whole length of guide wire inside. I try to, if it doesn't go, it's a different issue, but I try to keep the tail of the guide wire to a minimum, almost about a half a meter, because I do not need to take the help of my assistant, so that he will put this every instrument, he will thread it from a different distance, and then his guide, the guide wire is in his control, and sometimes we'll pull it off and do something else. It's a difficult scenario in that time. So I'll keep the tail to minimum, and it's just standing between me and the patient, and everything is easy, everything goes inside smoothly, and you can do it. So dilatation of the tract is easy. There's a mini PCNL dilatation. So you need to dilate, always under dilate. It's almost a common issue. I'm just telling the differences, what I do differently. During dilatation, one more issue you will face in supine PCNL is a movement of the kidney. You can see on the left video, the moment I try to dilate, the moment I try to push, this kidney is getting pushed and it's not going inside. So it's a problem. So how to counteract this problem? You can just press your hand on the abdomen for a brief moment and just thread it. It will go inside because the kidney is stabilized. It will not go opposite side. And one more thing I wanted to tell, that the rotation of the patient. You can see that erector calyces all are lateral to the spine. It's not overlapped. So you will not miss a stone in my position. Many have seen turning slightly more in upper calyceal puncture. I also usually turn the patient slightly more, but once you turn the patient slightly more, or almost like a semi-lateral position, or even a exaggerated in say elevated trunk, upper trunk, so everything will get rotated and these things will overlap on the supine, on the spine, and you will miss the small stone fragment, because you cannot differentiate from a bone density, from stone density from a bone density. So uh, as I was saying about the guide wire, you can see in the second video, I've kept the tail so short, and the tray is beside me, everything is accessible to me, and I can go in easily. I can just rotate, rock my chair on the opposite side, this side or this side, whichever side I have kept the things, and you can just keep it. See, my assistant is just standing there and watching the procedure, patient is also watching the procedure, and I am free. I do not get distracted, or he cannot make mistakes. I can make everything. The things mistakes will be made. It will be mine only. But interference of the other persons will be less. So after that, starting from a small stones and these things, I went on to go for supine PCNL for all the cases. In this case, there was a bifid system. I could not put the picture. The upper stone was in a different calyx and different bifid this pelvis, and the lower stones were in a different system. I could see three tracks. Three tracks were made in supine, and all stones were cleared. So if multiple tracks are also required, it's not a problem in a supine position. And usually many others have taught, or our teachers or seniors are teaching, that you initially puncture whatever you need to puncture, place the guide wire, and then do the procedure. But for me, I feel more comfortable without the puncturing initially all the tracks which I require. And sometimes I feel that I require 2 tracks, but it gets completed in a single track. Sometimes I feel that I require 1 track, but it will take around 3 or even 4 tracks. So I puncture as and when needed. It's not an issue for me. And you can see in the third picture that a Foley's catheter has been kept in the track. And what I do is clamp this Foley's and inflate the bulb to around 2 to 3 cc. Then again, the system will be completely closed. You can do RGP can puncture. And another advantage of puncturing at that moment is kidney is stable, and you know the direction of the puncture needle or the direction of the track. The other tracks also should be parallel to that, so not make much mistakes in going or finding the different calyces. About the supracostal the last is only about the supracostal the upper track, upper calyx. This upper stone was in a different system, bypass system, superior calyceal puncture. It was the supra 11th, probably the supra 11th puncture. It was done nicely. You can see in the second picture also the superior calyx puncture, and then multiple stones in the other calyces, but it was clear. And the video superior calyceal puncture and fragmentation of the stone has been seen. You can see the superior calyceal puncture by the direction of my nephroscope, because it's going down. So it's a much comfortable puncture or dilatation for any axis of the either middle or lower pole. And you can see the punctures all are in the tip of the papilla. One more thing I was worried about initially, that whether I will be able to go to upper pole after puncturing the lower pole or not, whether I will go to lower pole or mid pole after puncturing other poles or not. But in this and many other cases also, you can see even I can go to the mid pole after puncturing the lower pole. The maneuverability is more because the kidney is free and it will turn. Suppose I've entered to the lower pole and I want to go to upper pole. Do not expect that it will be like this. When you rotate your system, the kidney will move like this, and then upper calyx will be straight to your orientation. If you move more, you can also enter the middle calyces. And there's a contrary to the belief, the smaller the scope, more the maneuverability. I've seen I could reach the stones in the middle calyces with a mini nephroscope, which I could not reach with a standard nephroscope or the 20 French nephroscope which I use. You can see in the CM, I can go to the lower pole, or ureter, I can go to the upper pole. It's not much problem. One more thing I forgot to mention, that during dilatation, you cannot see the guide rod. What I've done is I've cut my guide rod just about 5 or 6 centimeters longer than the ampulla's length. So it's comfortable, because if you keep a longer guide rod, it is almost here for you to dilate. And your working environment is a distance between you and the patient. It's not like a prone patient that you'll get all the air of the until the roof or until your CM or until your this OT lights. You'll get just that much space only, because then you have to rock back and forth, and then create sometimes problems. If it is long, if you are dilating slightly cephalad, then you have to bend it like this. So modify the guide rod, keep it slightly short, or cut it according to your comfortable length. Actually, it was blessing in disguise. The supplier which provided me, he has provided me this short one. I have started using this short one. I was very happy with that, because that long guide rod was creating much more problems. So moving to the lithotripsy. Yeah, you can see the pneumatic lithotripsy, you can see the laser lithotripsy, and you can see once I come out, the stones will gradually come out. Water is almost coming out every time. There's a low pressure system, and the system is low pressure, and the stones will come out automatically. There's very less need of the grasper, and I use it only sometimes because I do not want some fragment to migrate here and there. And most of the times I'll fragment the stones small. I do not worry about the movement of the fragment. You can see in the first picture, it's breaking and it's coming out. It's breaking and it's coming out. We do not need to grasp all the fragments and take it out repeatedly. It will come out on its own. Very few times will require use of the grasper. So the procedure also is fast. The problem arises in lithotripsy when the lithotripter rod is slightly longer. So the advantage which is there of cutting that guide rod, it's lost in lithotripter, because again you have to come back, and then sometimes there's a direction is like this. It's in between your body and your the patient, so you cannot take it out. So you have to slide back or then rotate, then you have to take it out. But if you have a good rotating chair, it's very comfortable. You can just turn to this side and you can remove the uh, lithotripter rod or the rod, or you can just then insert your grasper. Grasper is also slightly longer. Sometimes we'll face problems when you have anterior calyces, then for you have to bend down and then slightly go there. But it's very rare, and you do not require in so many circumstances. One more problem is what I faced is I get drenched in water, because the water will continuously flow out. The water requirement is slightly more, and the water will follow the course, and water will follow the course of my nephroscope. It will come from the nephroscope to my hands, and it will go on seeping here. So I need a waterproof gown or a protection. I usually use that, and then it will from the water inlet also, it will continue dripping. This dripping of water, this in the fourth picture, that water which is dripping down from the scope. You can see the water is running around my. You can see when I. Hello.
You have stopped screen sharing, so you need to share your screen again.
Okay, so wait. Am I disconnected?
No, you are there on the platform. But
Okay. Just I will share the screen. I do not know something happened. It's coming.
Yeah, it's visible.
Yeah.
Left, right.
Yeah, you can see in the last picture, as I go down, the water will start dripping and coming across my hand. And it will come off. The second place from where water will come off is the inlet channel of the water of the reservoir head. It will follow its track and hangs down. It makes a sea loop, and from that sea loop, it will continue dripping on your body, on the floor. So floor becomes slightly messy. I'm adapting this. I'm still adapting how to minimize this. I've been using, you can see that I've been using plastic drapes. I've been using PCNL drapes. PCNL drape helps quite a lot, but the drapes are not waterproof. And again, the water will drip off from here and there. I've started using that floor suction mop. It sucks the water very nicely. So it's very efficient. And I've started wearing this waterproof lowers and boots. So it's quite helpful. And this small disadvantage, it's much more advantageous for all the other things. So I keep doing supine. After that, when we clear the stone, it comes to placement of the DJ stand. Sometimes every one of us have face this issue that we are placing the DJ stent, it's not going. It's not going because there's a kink in the ureter. It's not going because there's a small stone fragment which has lost into the ureter. It's not going because we cannot find the PUJ. There's so much edema or something like that. So you need to flip the patient, and then again you need to go from below. And again, the stent is not going. You will toil hard. You will take around half an hour, maybe sometimes 1 hour also. I have faced the issue that stent will not go, and then you have lost the track from above, you lost the track from below, and become sometimes messy. You have to just come out of the patient tube, and many of the times after flipping the patient again, stent will go, but it will take time. So one more advantage is, if there's a slight hesitancy or slight disturbance in putting the stent from above, or many a times what happens, you place the stent from above, again it will require slight maneuvering, repositioning to confirm that the upper coil is nicely set. So you can just, after finishing the procedure, keep the sheath there, just come over to the come over between the legs and place the stent from below. You can also do this. Sometimes I did on 2 centimeter stone in the pelvis, and small fragment got lost into the pelvis. The guidewire is not going from below. Again, I have to take URS from guidewire was not going from above, so stent also could not go. I have to come back and then do like a pushback PCNL, do a URS, and then with difficulty stent went. But because both the approaches were available to me, so I could do it easily. So after putting a stent, you need to come out. The exit strategy should be there, and you can see in the first picture, it's nice. It's coming out from a nice calicial cup. Okay, and the second picture also is a slight bleeding, but it's also coming from a nice calicial cup. So you can confirm that the puncture is good, and you can see that bleeding will stop. And the moment you come out, mostly the bleeding will stop. And you come out, keep seeing the track, keep seeing whether you have entered the colon or not, or any other organ. You can see nicely recognize that the gerotas have come, the dorsolumbar fascia, you have come out, you have come out of the muscles, you have come out of the sheath, now you're in subcutaneous fat, and ultimately you are out of the skin. This is a very fat patient, so it took time to take up the video also. After coming, what's my strategy is, once I come out, uh, many of the times I do not, if I anticipate that the procedure is gonna get over in within an hour, I do not place Foley's from below. Only there's a ureteric catheter, because many a times I need to go from below and to put a stent. And also sometimes because I leave the CM to me only, and I keep the CM in a fixed position. Once fixed, it doesn't move for a dilatation or for anything, because it covers the whole area of my interest. And sometimes you need to move it, but most of the time it covers my area of the interest, and it do not need to be moved. Sometimes coming from above to see the lower coil of the DJ stent, it's difficult sometimes. And I've seen few cases in which what happens is, when you have a Foley's in situ, you'll, because Foley's will rest above the ureteric orifices in many times or many situations. So when you pass the guidewire will go from there, and it will guidewire, instead of coiling in the bladder, sometimes it goes directly into the urethra. You place a stent, and the stent distal end is in urethra. Again, you have to flip the patient, you have to push it, sometimes by pushing the Foley's, or just removing the Foley's, putting some jelly, reinserting the Foley's, it goes in, but sometimes you can accidentally pull out the stent also. So I do not usually put my Foley's in at the outset if the anticipated procedure time is less than 1 hour. And many a times I will confirm my stent position, the lower coil, directly by doing a cystoscopy. It takes much less time than repositioning the CM to the pelvis. So after you come out, there are small holes in many PCNLs, or there can be 3 or 4 holes if you have multiple tracks. You can see the three tracks. The first track was biggest, second was smallest, and third was much smaller. I usually go to the smaller ones for a smaller calculus. You can see the first image, ureteric catheter has been pushed. The mini PCNL, it's almost hardly around 5 mm, and I usually put a stapler in. Sometimes when stapler is not available, I will go on with the sutures, and the next day I discharge my patient. If something happens or there's some delay, they will go on the day after, means the on the second day, and I'll remove the stapler on that day only, on the day of discharge, so that do not forget. I'll just put a band-aid or hansaplast on that. I'll ask the patient that they can this take part daily, and they can remove this band-aid and reapply it again if they're afraid of the infection, or if they're afraid that it will pain. After 15 days, the patient cannot, it's difficult to find the scar. It's just a dimple. So there's an advantage, one more added advantage to this supine PCNL is that you can do ECRIS. I'm working alone in my hospital, so there's no other surgeon available who can do a simultaneous URS. So I have to move back and forth from to lithotomy to supine position, or from lateral side of the patient to lithotomy, or in between the legs. So you can see in this patient, it was a redo case. Actually, it was full of stones. I could clear all the stones, but three stones were in a different calyces. I could not clear it. So I thought of combined technique. I cleared one stone with PCNL, and the second stone, which was very difficult to access and puncture also. Last time there was bleeding finding that stone, so I did not wanted to take any risk. I could go with flexible nephroscope, and with the flexible nephroscope, the patient is pre-stented. This patient was pre-stented, so I could go on from below. The patient is not pre-stented and you want a small calyx which is not, you can see the stone but you're not able to reach it, or you cannot reach from that puncture. Is very small stone, you do not want any extra puncture, you can directly go from a PCNL tract also, and you can search all the calyces, you can search the stone, and there's a minimized trauma to the kidney. So the combined technique also is helpful, and this technique, you can see through the PCNL tract, you can see my flexible ureteroscope that was searching for the stone. So in upper ureteric, this ureteric calculus, also we face difficulties that we push the stone, we flip the patient, we go in and we found that the stone is way too far in the ureter, it has moved down. And sometimes you are trying to push the stone or trying to reach the stone, you're not going to the stone because there's a kink, and you are not able to see the stone, you're not able to pass the guide, you're not able to reach it. So what you do is, in desperation, okay, I will flip the patient, I will try to puncture and try to reach from above. And at that time also you do not succeed. So when there's a combined approach, you can yeah, puncture the kidney, and after puncturing, when we just press the amplas or your sheath downwards, the kidney will get move up and the kink will straighten, and you can pass the guide wire from below. It's very helpful. And once you pass the guide wire, you can just retrieve it, your axis is complete, and then you can manipulate from both the sides, and most of the time you will be able to clear that impacted upper ureteric calculus. Even if some stone fragments migrate or some stone fragments are still there, then you have an option to go back to the lithotomy or go back in between the legs. So that was it. uh, I've told you about all the problems I faced, what I did, and what I'm doing. The next plan is ultrasound guided supine PCNL. I'm I have done many ultrasound guided PCN even in supine, but PCNL, it's the next plan I want to do. Most probably I will do. When there's a meta-analysis between prone versus supine, Many meta-analysis have said there's a less operative time, there's similar stone-free rate, and mostly they have said that there's a better in supine in high-risk patient and multiple calicial stone. I'll not go into the details of the study. So, given the benefits of the modified supine position for surgical and anesthetic team, particularly in the obese patient group, it should be considered by all the surgeons performing supine PCNL. So, sorry. So my thought at supine PCNL is the way to go, and only a blind and not foreseeing ostracism can prevent you the experience, the clear advantage of the supine position. No more excuses. Try supine PCNL and you will love it. I say that you will love it. I am loving it because you can cut almost your 1 hour. I have done around 2 centimeter stone from gloves into gloves out within 25 minutes also, and everything goes smoothly. So my thought is that prone PCNL should take the occasional job and supine PCNL should be the standard of care. Thank you.
Thank you very much, sir. Thank you very much, sir. Thank you for your wonderful session. So till now we are not having any questions. But can you wait for 1 to 2 minutes more for the delegates if there's any questions comes?
Yeah, if there are any questions, you can tell me, you can forward it to me.
Yes, sir.
Hello.
Yes, sir. Tell me.
Yeah, are there any questions or I can wrap up?
No, so still we don't have any questions. So with your permission, shall we continue? Hello. Can you hear me? Hello.
Yeah, tell me.
Yeah, I'm asking. Still there are not any questions. So with your permission, shall we conclude? Hello. Am I audible? Hello.
Yeah, you are audible to me, but you are talking to the team, I think so.
Yeah, I'm asking to you, sir. There are no other questions till now. So with your permission, shall we conclude? Hello. Hitesh, sir. Can you hear
Yeah.
me?
Yeah, I can hear.
With your permission, shall we conclude, sir? There are no other
Yeah,
questions.
we can conclude.
Okay, thank you very much. Thank you for
Thank
your
you. Thank
valuable time.
you.
On the behalf of organizer, I would like to thank you for your insightful and informative talk. Thank you very much.
Thank you.
Yeah, bye.